I'm Daryl Baskin, and we're going to talk about retina imaging and electrophys. Please interrupt with any questions. So, question? No. No financial disclosures that are relevant or irrelevant. All right, so our overview, we're going to talk about, I kind of incorporated the parts that were most interesting to me. These couple of chapters that I have coverage over include things like visually evoked potentials and color vision, which there's really not enough time to talk about all this stuff anyway, so I cut out the really boring stuff, but you might still be responsible for that. These are the things I'm going to talk about, and not in that order: OCT, FA, ICG, autofluorescence, ERG, and EOG. We'll start off talking about OCT. It is a non-invasive, non-contact imaging modality that produces micron resolution cross-sectional images of ocular tissue. In my case, I care about the retina choroid. It also does optic nerve, cornea, lens, all sorts of other things. And it's used in other fields as well. It's based on imaging reflected light. And the reason we always talk about low coherence interferometry is because with sound or radar or ultrasound, you can actually develop timing devices that can measure how long it takes for that to get back. But with light, it's so fast that we really can't just click a button when the light leaves out and then click another button when it comes back and say that's how long it took. It takes another technology, which I'll show you in the next slide, to really see how long it takes for that light to get back, and then figure out the distance from the image, the source. It's a higher resolution than ultrasound due to its faster speed of light than sound. I don't remember those off the top of my head, but and then the axial resolution depends on what we call the coherence length of the light source. So, looking at this image, let's see if I can bring a cursor up, and let's see, it's going to come over. Nope, I have to go this way. Okay, that's a little bit on a delay. All right. All right, so we have a light source there, and I don't know if I can really do this because there's such a delay with the cursor. It comes to this beam splitter. It's a partially silvered mirror, so some of the light goes straight through and some gets reflected, right? So some of it goes up to this reference beam. Oh, I just can't deal with this. All right, I'm taking the cursor off. You're just going to have to follow my words here. Goes up to this reference, or to movable mirror up at the top of the screen, and then that light bounces back, comes back to the beam splitter, and then passes all the way through it down to the light detector at the bottom. Some of the light goes straight through it to the retina, in our case. And then that light bounces back, hits that beam splitter, and is totally reflected this time and hits the light detector. And what you're doing is, if you have and again, this is time domain OCT. This is the easiest way to understand it. With spectral domain, it's kind of like you throw up your hands in the air and go. It's Fourier transformations, and nobody understands. By the time you understand that, you've forgotten like the first 5 steps of how you understood that, and you just can't actually explain it to anybody. But basically, with this movable mirror, you have it at a certain position, and then in this case, they have it at the number 7, and then for the retina, they also have it at the quote unquote number 7 position. And if you hit something that's hyperreflective, in this case, we'll say the RPE, when that light bounces back, hits that mirror the same time that it's coming back from the reference arm, the movable mirror, and then it comes down and hits the light detector in phase. So they're kind of, that whole wave thing. When they hit in phase, they get this additional sort of bump in their reflectivity or amplitude of the reflectivity. You can see down where there's 2 little charts at the bottom. The one on the left says position of movable mirror on the bottom on its x-axis, and the y-axis it has output of light source. When they both hit, they get this little spike. If you have some light coming back at the same time from somewhere closer, when you still have both the mirror position in 7 and you're looking at the RPE at 7 or whatever, if you have something come back at 5 or 6, it's going to come back at a lot lower amplitude. Okay, it's that whole, when we do these, what do we call it with eyeglasses, when you actually have that coating on there that decreases glare or the reflections that you get off of people's glasses, like Jared's. What's that? Not polarized. It's a special coating that goes on the surface. It's an anti-glare, and so what it does is it's like a quarter of the wavelength of light thick, or wavelength of 520 nanometers, or whatever the common wavelength of light color is, and it reflects that light back. If it's a half wavelength thick, it reflects it back, or a quarter, it reflects it back at a half, and then that cancels out the reflections. Does that ring a bell? Okay, we're kind of doing the same thing here in this little red bullseye looking thing over on the right is basically a coherent or interference pattern. So you get bright, dark, bright, dark, bright, dark. With spectral domain, what we do is we don't have a movable mirror anymore because it actually takes time to do that. We basically just have all this light reflected back. This is my understanding. And then we have this ability to apply a mathematical equation to it and figure out where it came from. And that's all you need to know. I'm already giving you more than you need to know. If you say Michelson, coherent or interference, blah, blah, blah. If you say Michelson interferometry, you basically have the principle of OCT. So nobody's going to make you explain this in a mock oral setting or regular oral setting as far as I know. Let me see if I'm forgetting to say anything else here. Oh, and then that bottom right one, if you tilt the mirror a little bit, you could shine that light into the retina at a slightly different place laterally, and that's how you get a B scan. So, all right, let's go to the next slide. Arthur C. Clarke said, any sufficiently advanced technology is indistinguishable from magic. Again, spectral domain OCT is like magic. All right, this next slide is the most important one, and I'll if somebody will remind me, I'll just send this to everyone. I wish I could have been in this group, but I wasn't invited. The International Nomenclature for OCT meeting happened, I think, this year, or 2013, I should say. And they came up with they finally agreed on what we're going to call all this stuff, so you don't hear people saying, now if somebody says ISOS, you can really make fun of them officially. Although this hasn't been published yet, so maybe you should wait. So, but this is like all the layers, and I think there's a few important ones. Again, I can't point. Gosh, it's going to really drive me nuts. Let's see if I do that. Does that work? No, let me try one more thing. I thought there's a cursor. Show where I had the pointer. Yeah. Well, it wouldn't matter if I had a laser. I could teach you guys with a laser pointer. How's that sound? All right. Okay, so we're starting out. It doesn't really show up that well. But starting out looking at, all right, fine, I'll try to do it this way. Okay. All right, I want to point out they have the junction of Henle's fiber layer and the the outer nuclear layer here. Again, this cursor thing's driving me nuts. It's very subtle, but it is there. We talk about this being, I don't know if you remember in the last lecture that I gave, we talked about the Henle fiber layer. You could think of the OPL, the outer plexiform layers, having like a hyperreflective inner third and a hyporeflective outer 2/3, and they talk about that in this slide. They call it the Henle fiber layer here, or in parentheses, axonal outer plexiform layer, versus this dendritic inner portion. Again, I can't really slide this cursor over very well. The other thing I want to point out is, of course, we are calling this ellipsoid zone officially. See, I've been doing it for a long time. You guys have been getting good information from me the last year. Interdigitation zone is the bright hyperreflective line below that. The myoid zone is this hyporeflective layer between the ELM and the ellipsoid zone. Because, again, we're looking at above the ELM, you've got the outer nuclear layer. The ELM corresponds to where those Mueller cells come in and attach at the junction of the nucleus, the outer nuclear layer, and the inner segment. And the inner segment has those two parts. Remember, myoid, ellipsoid zone. So the myoid zone is actually hyperreflective. The ellipsoid zone is that really hyperreflective one that we previously called the ISOS. And then below that hyperreflective layer below that, those are all outer segments. So they've actually labeled that, I'm not going to try to point at it, right in the center of this guy's fovea. Below that, you have the interdigitation zones referring to the disc, the photoreceptor, the outer segments interdigitating with the RPE apices. And below that, we kind of have this line that is the RPE plus its Brooks membrane or Brooks complex. And in some pathologic states such as CSR or sometimes AMD, you'll actually get a separation of those two. Choriocapillaris, they actually label Sattler's layer and Haller's layer in the choroid. You can't really tell the difference between the two. They just put those in there. And remember, Sattler's is in the center, so choriocapillaris, Sattler, Haller. And then they actually kind of go through and talk about, that's the posterior cortical vitreous in the upper right preretinal space, et cetera, et cetera. But this is probably not spectral domain OCT. I mean, it's spectral domain, but it's probably swept source, which is kind of a subcategory of spectral domain. Uses a slightly different technology that's awesome. Okay. Next slide. All the rest of the slides are not nearly as great as that slide for the whole lecture. Here's a couple of tips when you're looking at OCTs. I'm going to kind of read off of these. Make sure you have the right person. It's happened to me. It'll happen to you. Look at the signal strength index or equivalent. Not as big of a deal as spectral domain with some of the other ones, the older ones. That was a really big deal. Determine if there's artifacts. or you're looking at multiple B-scan averaging. Almost all of ours are average these days. Well, Cirrus isn't, but that's important to recognize. You can do that with Cirrus, but our default pattern here at BAMC is not to average. Look at all the scans, radials, volumes. Look at whatever you have, especially if there's a question about somebody saying, hey, I think I'm having symptoms. They have a history of AMD. It's wet in one eye, dry in the other. Go back and look at the computer. Change the brightness or the contrast. Take it off of color. You never want to look at an OCT in color. Analyze it from top to bottom. Kind of be somewhat just like you look at a color-funded photograph. You have you talk about the media, you talk about the optic nerve, the vessels, macula, et cetera, et cetera. You want to do the same thing with OCT. You want to kind of have your standard algorithm. The worst thing you could do is have somebody coming in and you didn't give them an injection the time before because you thought they were normal. This time they definitely have fluid. You look back, there was fluid last time and you missed it. Okay? I've seen a lot of patients that where I'm seeing them for the first time, and I cannot tell you how many times I've seen that in the last 6 months. And it's really sad. Vision does not get better when they've got fluid under their retina or in their retina. All right, so look at the thickness maps. Decide if the boundary curves are appropriate. Again, we're talking about segmentation. You get an automatic segmentation that gives you the retinal thickness. For DME, it's almost always accurate. For BRVO, same thing. When you get to AMD, it's really hard to segment because you get this lumpy, bumpy outer retinal band or line that they look at with the RPE. They don't always segment it correctly. So, or if they have some weird stuff going on in their epiretinal membrane, or with a VMT, they're going to get it wrong. So you don't want to let that decide for you whether you're treating somebody or not unless it's accurate. I could give a whole lecture on vitreomacular abnormalities, but we're not going to. Suffice it to say, it's very important. This is one of the most revolutionary parts of OCT is being able to see the vitreomacular interface in a way we've never seen it before. Okay, is the contour normal? If it's not, why isn't it? And then retinal thickness, again, you need to know your segmentation. Is it too thick, too thin? Which layers are making it too thick or too thin? You can diagnose a BRVO or some interretinal vascular abnormalities very easily if you're just looking at which area is thinned out. And then NB or nota bene, or something like that in Latin. All the Harvard professors like to put NB in there because it, gets some Latin. Latin means you're learning something good. Try to find normal part of the retina and then trace over to the abnormal part. Okay, that'll help you find your normal anatomic boundaries and markers. We're going to talk about FA. I think FA is becoming harder to understand because we don't use it as much. Not that it was easy when I was a resident, but it's fallen into disuse to some degree. In general, we all understand this idea of fluorescence. A photon of light hits something, an atom, the electron gets excited. The whole molecule or the atom is excited. The electron goes up to a higher orbit, and when it descends down into its normal orbit, it gives off a photon of light that happens to be of a different wavelength. That's called fluorescence. Fluorescein, sodium fluorescein, does that. That's the molecule on the bottom left. In general, we shine in blue light at 480 and it comes back at us at 520. That is not actually the way it works for some of our platforms, especially the Optos 200TX. We're not going to talk about different platforms, but just suffice to say it doesn't always work exactly like that. I'm mostly going to read off this slide. 80% of fluorescein dye binds to plasma proteins. The remainder is unbound and can be visualized. So the part that's bound is not the part that fluoresces. This will be different with ICG. It's metabolized by both the liver and the kidneys, eliminating the urine within 24 to 36 hours. And then you want to use lower doses in patients with renal compromise. It has never been associated with any kind of nephropathy. Just like there's contrast-related nephropathy, there's no such thing as fluorescein-related nephropathy. If somebody says they have kidney disease, it's not a contraindication. Nausea or vomiting in 10%, especially if they're younger. Extravasation and necrosis can happen if you're not paying attention and you're just squirting it right under their skin. They're not going to like you. Urticarial reactions in 1%, anaphylactic reactions in 1 in 100,000. Most of you have heard, if you've heard me give this lecture, my grandmother had a sort of an anaphylactic reaction, ended up in the ICU for a few days when she had a fluorescein. So she lived through it, but you definitely want to make sure they know that we're going to catch these people, but they need to know that there's a substantial risk and that something bad could happen. So at least counsel them briefly. We're going to talk about fluorescein, but I'm going to explain it with OCT to some degree. Retina has a dual blood supply. We went over this in my previous lecture last week. basically, when you talk about the inner retinal blood barrier and the outer retinal blood barrier, these apply to fluorescein. And unless there's something wrong with the retina, which is why we all are interested in retina. If the retina was always normal, it wouldn't be that interesting. If there's something wrong with it, then things are going to leak through. So when you start your fluorescein angiogram, actually the large choroidal vessels do not allow fluorescein through them. It's the choriocapillaris that has the fenestrations that are facing the RPE that lets it through, but basically it fills up the whole choroid. That supplies the outer portion of the retina. I drew a blue line there. I don't know if you could see it. Basically where the RPE is, the zonulae occludentes, if that's the way to say it, provide that outer blood retinal barrier and keep the fluorescein from coming forward. But they also, fluorescein does not fluoresce brightly through the RPE because of its wavelength. So you get this kind of mild fluorescence that you would see normally. Okay, and then the fluorescein is also constrained within all the retinal blood vessels. So choriocapillaris has fenestrations, leaks out the fluorescein all the way through, generally speaking, whereas the retinal vasculature, those pericytes and that endothelium really blocks that fluorescein from getting out. Okay, so rule number 1, the retinal vessels do not leak. All right, kind of covered that. Rule number 2 is coming. The RPE acts like a curtain, so it kind of dims that fluorescence that comes through the choroid. Rule number 3, and the choroid leaks fluorescein like a sieve. That's a Gary Laneism. Doesn't really leak it like a sieve, but it's throughout. This is, so we talked about why the foveola is so dark before. We mentioned in that lecture last week, the RPE in the center has 4 characteristics. It's taller, it's thinner, so you get them more packed in. The melanosomes are bigger and there's more of them. So you've got all these reasons to have, just from the RPE, a darker foveola, but also you've got xanthophyll in the neurosensory retina, and then you've also got the absence of retinal vessels. So those are your reasons why your foveola is so dark. This is the patient with CSR. All right. This is a little movie. This is not normal, but I think it illustrates some of the characteristics of a fluorescein angiogram. I don't know, one of you might have even given this person their fluorescein. This is like a year or 2 ago. All right, this is terrible film quality for everybody else. Well, for you guys too. But basically what you see happening is a pulsatile nature of the filling. It's all kind of going in slow motion more or less. So you're not going to see my pointer here that well. But what you're going to see in a second is this patient's vasovagal, so they have a really low blood pressure. So you got that patchy choroidal lobular flush. The timing, of course, is going to be off. I think I blocked off the time anyway. And what you see now is the patient kind of falling backwards. Let's see if I can freeze it. That's the patient falling backwards a little bit. I'm just going to page through it because it'll be a little bit easier. See, now you see there are 2 eyeballs, and then they just flashed out.
Is that a young female?
Probably. Does this ring a bell for you? Good.
Did you do it?
Dana Anderson made this poor young lady pass out.
Great.
So, but what was interesting about that is you got to see it kind of going in slow motion, and we're going to go through and talk about all this stuff in a moment. So, okay, when we talk about fluorescein, we usually want to talk about, are things abnormally bright or abnormally dark? When we talk about abnormally bright, we use the word hyperfluorescence. If they're abnormally dark, it's hypofluorescence. If I confuse those, I apologize. So, and then if you think of it as hyper, in this case, we got something hyper. I've got an early and a late. Early's on the left, late's on the right. And you want to characterize it. Is this, what type of hyperfluorescence? Is this staining? Is this pooling? Is this is this leakage? That kind of thing. So in this case, we see some hyperfluorescence in our first slide on the left. And then on the second one on the right, it's brighter, but it's not expanding beyond those borders. So anybody want to say what it is? Sam, what do you think? No, we're not going as far as like a clinical diagnosis. Is it? Do you think it's staining, leaking, pooling?
Definitely not leaking.
There you go. So it's staining.
Staining.
So, all right. So that one's staining. This one is brighter on the right, and it kind of blurs its borders. So we think of this as leaking. And this particular configuration fits a little bit more with like a CNV, but other things can cause leaking too, like cystoid macular edema. So when you see leaking, you don't just go CNV or CME. There, you could even think about other things too. So again, leaking NVD or NVE causes leaking, but that's obviously not cystoid macular edema. It's obviously not choroidal neovascularization. So leaking. So you can keep on subcategorizing. This is a good way to think about anything with ophthalmology is take it one level more detail. So, okay, here we see abnormally bright at the disc. Forget using a pointer. Abnormally dark in the macula, right? You can see this little kind of web-like ring around where the fovea vascular zone is. And then oftentimes before you kind of commit to a diagnosis, you need to see the color. Because theoretically, maybe, I wouldn't say so, but maybe you might say, well, it's dark, but could it be a blocking defect? Well, probably. Just looking at it, the vessels are all pruned off. It's going to be a filling defect, right? And looking at this, you go, okay, there's not a big chunk of hemorrhage right there. So this area in the center that's hypofluorescent, that's a filling defect. Okay. This one's harder. I wish I'd left this red ring off. I thought about leaving it off last night. You could barely tell. In fact, let's see if I can go back one build. Yes. All right. So you can barely tell that right in the center, it's a little bit darker. It's kind of like a lazy T-shaped thing. And as you can see on my next little outline there, I'm outlining this area. It's a little darker. You can see vessels. It's probably not a filling defect, but it could be a choroidal filling defect. That's not easy to diagnose. It could be choroidal filling defect, or it could be a blocking. In this case, we see the color, and we see it's blocking. We got all this old exudate, right? So it's blocking choroid. You can block retinal vessels as well with like a pre-retinal hemorrhage, right? And that would give you hypofluorescence. All right, we're going to kind of go through really briefly the different phases. You got your pre-arterial phase, which is 10 to 15 seconds after injection. You start to get a choroidal flush. And I've kind of highlighted over here with OCT where the fluorescein is right now. Now, this guy is actually not normal. This is a person with a central retinal artery occlusion. Look at the time. It's 30 seconds. That's really late. And he's got the ciliary retinal artery that's filling. And his retinal vasculature is not that good. So, CRAO. Okay, so now you've got an arterial filling phase is about 1 to 3 seconds after your choroidal flush. Lasts about a second. It's very early. This guy actually has patchy choroidal filling. He has ocular ischemic syndrome. This is a patient of mine during fellowship. Okay, and then 10 to 11 seconds after a given artery starts to fill, you should see its corresponding veins start to fill. And this is what we call venous filling or late AV. You can call it laminar venous if you want. We're getting really sloppy with our terms these days anyway. Like I said, we're not doing fluoresceins as often. This person also has an old C&V, and they've got hypofluorescent lesion in the center, probably due to blocking, due to this RPE hyperplasia. I'm not going to show you the color. But again, this is to illustrate venous filling. If you look outside of the red circle, this is kind of what it normally looks like. Laminar venous filling. And your peak fluorescence is not something we talk about a whole lot, but about a minute after injection, you get the brightest fluorescein you're going to get. And that's great for looking at diabetics and really getting a sense of what's going on. I've highlighted or circled something here with that red. Jared, have you seen this? And it's a little darker. Do you know why it's darker right there? Do you think it's a filling defect or a blocking defect? It's a little hypofluorescent right where I've got that circle. Here, I'll go back. See if I can go. Yeah, you're right. It's blocking. There's a very thin subretinal fluid. It's a patient of mine with CSR. And let's go to the next one. All right, next. All right, and then again, it's hard to ignore the pathology. I should have changed the slide. Your mid-recirculation phase occurs about 1 to 4 minutes afterwards. This is a patient with a really rare condition called acute idiopathic maculopathy that I saw in fellowship. And that's a really interesting fluorescein to go through in and of its own on another day. Okay, so here you've got some staining of Brooks membrane, the sclera, and you kind of get this late recirculation. You actually have the choroidal vessels have been drained of all the fluorescein, and they're actually highlighting up in this negative kind of image there. And it's kind of, I don't know, it's interesting. It's not super important on most of my fluoresceins, but an ICGA will oftentimes look at late recirculation. So, okay, moving right along, let's talk about ERG. This, again, is a poorly understood, I think, way of testing the retina. And again, it's probably because we have other ways of doing things that are more non-invasive and quicker. Mass response from the whole retina, we also call it Gansfeld or full field ERG, and it's a brief flash of light. The way to think about ERG is there's 5 of them. And we might not get into ERGs too much because I really want everybody to get this. There are basically 5 responses that we ever talk about, and one of them we almost never talk about. I used to spend a lot of time talking about that one, and I realized that was worthless. So 3 of them are dark adapted, so we're going to talk about those first. So you dark adapt somebody for 20 minutes. So what you're doing there is you're allowing their rods to get all the rhodopsin that they need so they can respond. If I just gave you a bright flash of light right now, Sam, your rods would be kind of like, oh, we're already kind of tuned out because of all this bright light in here. We're not going to really contribute that much to the response. And what you're doing is you're shining a bright light and you're measuring the electrical response that the retina gives you, right? So there are 3 things that this is the most important one, the maximal combined response. Again, dark adapted and then a bright flash of light. So that bright flash of light is not just stimulating rods at this point, it's also stimulating cones. That's why they call it the maximal combined response. If you look at that little arrowhead, again, I can't point, that's pointing down, that's where the light comes in. Every ERG is going to give you some indication of when the stimulus occurs. Your A wave is that first deflection, and then the B wave is that positive response afterwards. In general, your A wave comes from your photoreceptors. In general, your B wave comes from like your Mueller cells and your bipolars. So when we talk about the amplitude of the A wave, it's right there. It's those dashed lines from baseline to the apex, or the negative apex in this case. What do we? Not the zenith, but the nadir. I don't know. The trough. We'll call it the trough. And then the B wave isn't from where you started out at your baseline. It's from the bottom of the A wave to the top. Okay. So let's see if I'm missing anything else I want to tell you about that. Okay. Oh, the next slide is really, the next little build. So your rod response, this is one of the big 4. It's important. It's not as important as your maximal combined, but it's a dimmer flash. That's why you have baby flash up there. See little baby Flash Gordon guy? It's not Flash Gordon. That's a different character, right? Okay, so baby flash. It's dimmer, and it's dimmer so why? You don't get the cones to respond, number 1. Number 2, you might say, well, I thought the photoreceptors contributed to the A wave, but we don't see an A wave here. Well, it's because the brightness of the flash is so dim that, yes, the rod photoreceptors are responding, but there's not very many of them responding, and it's not to the point where we can detect it. But if you notice, the B wave is there. So why is that? It's because you get these on bipolar cells that just immediately expand that signal from the rods. They get so excited about one rod detecting a photon, like, hey guys, we got something going on here, and they get a really big electrical response. So that's why you don't see an A wave, but you see a B. Okay. And then we also have these oscillatory potentials that I used to spend a lot of time on. We're not going to spend a lot of time on anymore. Okay. So what is the difference between the oscillatory potentials and the maximal combined response? It's the same flash, same length of time that it's on, same brightness. The difference is, let's see, this button. It's like really slow-mo here. All right. When you're doing the maximal combined response, you're looking at basically 0.3 hertz. You have a filter, okay? And it basically takes in everything between 0.3 hertz and 300 hertz. You know, your heart is when it's beating, you can't turn the heart off for one of these things, and it gives you a lot of electrical response. So you do another thing you actually put another electrode on somebody, and then you kind of measure their heart, and then you cancel that out. But you also get other noise from other things, even like brain waves. So 0.3 to 300 gives you most of what you need for the eye. If we cut that down a little bit, such that we're only taking 75 hertz to 300 hertz, that's where we get oscillatory potentials from. So we're taking this filter and making it even smaller. Who really cares about oscillatory potentials? I don't know. It's basically these feedback interactions that you get from the middle retinal cells, the amacrine, bipolar, horizontal, all those guys. And they're somewhat reduced in congenital stationary night blindness and some retinal ischemic states. I don't know if anybody's ever used it to diagnose anything. I'm sure there's some electrophysiologists like Dr. Harrison, who I thought last night, why didn't I ask Dr. Harrison to give this lecture, but he's not. And so I'm sure he has some scenarios in which he's used this. I do not. So, okay. Next. So now let's talk about the light adapter. There's 2 here, right? You have to be light adapted for 10 minutes. Why? We're bleaching out all the rods. So all that rhodopsin's depleted, I guess. And that's the way I think of it. That may not be true. And what you're doing is you're shining a bright light. Again, single flash cone response is probably the same bright light that should be the same one that we use in the maximal combined response. Again, I'm a clinician. I do not do these tests. If somebody wants to correct me, I'd be happy to take those errors and put them in my next lecture that's not related to ERG. So you got your single cone. Here's what's interesting. We've already dimmed out all the rods, but now we do this flicker. The 30 hertz flicker is done that way so that it doesn't give the rods enough time to respond. Well, we've already bleached out the rods, so they shouldn't have been responding anyway. But now we basically have put it at 30 hertz. I think, yeah, they can only respond up to 20 hertz rods, 20 cycles per second. But since we're going at 30 hertz, then, then we're definitely not including rods in that signal. And they've already been bleached out. And it's actually 30.3 hertz because 30 hertz will be in cycle with like the electrical signal when you plug into the wall, etc. So 30 hertz flicker, only cones. I don't know of diseases where you get a good cone response and a bad 30 hertz flicker. I'm sure they're out there. You don't need to know that kind of detail either. I made it this far without it. So why do we use the ERG? Okay, this is from the book. To distinguish between diffuse and focal retinal damage. So your multifocal ERG could help you with that too. This is my favorite quote from the book. Useful in evaluating chronic ischemic damage from vascular disease. So it may aid in the detection of certain hereditary disorders, especially like in X-linked carriers of like choroideremia, that sort of thing. And then if you want to estimate the extent of damage from trauma or drug toxicity, this might be one of the other great uses for it. You could, on the next slide I'll talk about the trauma, but from drug toxicity, let's say you actually you had a foreign body in the eye, want to know if it's causing siderosis, you could do serial ERGs. Not something we commonly do because we always take the foreign body out, but let's say there's a foreign body embedded somewhere that's hard to get out, we want to kind of wait. That would be one option. Okay, MINUTIA. Early receptor potentials, this is in the book. It's a small response, has no latency. It's probably related to this conversion of lumirhodopsin to metarhodopsin. The C wave is from the RPE, and it takes about 2 to 4 seconds before it occurs. And this bright flash ERG, which is quite a bit brighter than the regular one, is for, again, trauma patients that if they've got really opaque media, you're trying to decide whether you should operate. Again, around here, we just operate. So, all right. Okay, so here's one free example. This is a patient of mine who came in with nystagmus. If you look at her rod responses, we got a rod response. These are all right eyes, by the way. They just do it multiple times. Can't point, but rod response and a maximum combined response, number 1 and number 2, both look good, bad, normal, right? So then we've got this cone response and a flicker that look not normal. So, okay, if they have nystagmus, what do you think? What do you think, Rodriguez? Could this be a cone dystrophy? We've got nystagmus. When do cone dystrophies usually start? At birth or later? Early in their 20s and 30s or teens.
Exactly.
So are you going to get nystagmus if you start losing vision when you're 20? Probably not. So if they have nystagmus, they've had this since birth, you could infer. And this patient came in with this diagnosis, ACHROMATOPSIA. So what I want to point out is that cone dystrophies might look similar to the ERG, but if they have nystagmus, obviously you don't just judge this by an ERG, and it's very likely a cone dystrophy would look different than this anyway on ERG. What I want to point out, if you could see this, and I'll actually bother to get the pointer out for this, this is obviously the fovea. What did we say? 3 millimeters temporal to the temporal margin of the disc and 0.8 millimeters below that, right? You see a dark spot here. She had the same thing in her other eye. Anybody know why she has a dark spot there? It's a bit of a camera artifact. When they're really highly myopic, you can actually get something we call the Allen spot. But it's a camera artifact that's a little bit darker, and it usually tells you where they're fixating. And so she's not fixating in the center for obvious reasons. Her cones don't work. She's fixating about 15 to 20 degrees off, which is where your highest density of rods are. So, and I said 20 degrees off last week. This book, this chapter, I should say, said 15 degrees off. It's driving me nuts. Nobody will just come to an agreement. It's hard to test somebody if everybody's saying different things. All right, so autofluorescence. We talked about sodium fluorescein, fluorescing, right? We talked about the atom and the light photon coming in, electron goes up, the different photon comes out. Autofluorescence is that exact same process, but without sodium fluorescein. You could say this. You could say sodium fluorescein by itself is autofluorescent. It's autofluorescent to itself. It's kind of confusing. But just think of, autofluorescence is like basically looking at a fluorescein angiogram, but with no fluorescein. So anyway, in the old days, we talked about there just being 2 or 3 things that ever autofluoresce. These days, we talk about everything autofluorescing. Okay, main source is lipofuscin. I have a whole lecture on other things that can autofluoresce, but we're not going to talk about that. RPE cells that are normal have this kind of mild autofluorescence. Sick RPE cells are hyperautofluorescent, and then dead RPE cells are hypoautofluorescent. I've got drusen up here from a really cool autofluorescent image that I got off of a guy from like Kazakhstan or something. But the thing to remember about these RPE cells is that you can prime, or when you're doing one of these FAs or FAFs, you can prime it a little bit. So if you just shine that blue light in for a few seconds and then take your picture, it's going to be somewhat dim. If you shine that blue light and really torture the patient for a minute, which you probably shouldn't, it's going to be really bright. So there's a lot of variation in terms of the brightness of the image that you get. We need to move along because I only have 9 minutes. This is subretinal fluid. Again, it attenuates that signal, right? That's due to acute CSR. This is chronic CSR. This is that guttering thing you hear me talking about all the time. It's got hyper on the edges, hypo in the middle, unhappy RPE all around. This is a patient with chloroquine toxicity and hydroxychloroquine. And we've got somebody with subretinal drusen in this leopard pattern. This is a nevus, or maybe a small melanoma that's got orange pigment. I'll talk about that more next week. That's hyper autofluorescing. And then this is a patient with, anybody want to guess? Brent? It's hypoautofluorescent in the center. So there's some kind of atrophy of the RPE there. We have multiple, I'll call them flecks, of hyperautofluorescent material outside of that. Like a pisiform, like a Stargardt. And let's see what's next. Okay, and this is a patient with a cone dystrophy. Nice. That actually looks like a bull's eye, doesn't it? Or a human's eye, for that matter. This is the patient's color. Okay, and that's their OCT. All right, let's move along. Okay, ICG, you only got a few minutes. What do you need to know about it? It's got a wider spectrum of absorption and fluorescence. It's almost all protein-bound, and the protein-bound portion fluoresces. Here's a more important slide. It's got a longer wavelength. It fluoresces through the RPE. It does not exit through the fenestrations of the choroid. Those two things, if you remember nothing else. Plus, I'll kind of fly through 5% iodide. So you got to ask your patients, if they have contrast allergy, they shouldn't get this. And if they're on metformin or have liver disease, they also shouldn't get it. If they're on metformin, you have to see if they could stop it for, I think, 72 hours. Nausea, vomiting, rare. I have a friend whose patient died after he injected ICG. So just be aware. It's not as common as fluorescein, but in terms of side effects, but it can also cause problems. I drew circles around the choroidal blood vessels here just to remind you. Let me go back a second. This is a great image. On the left, you see an ICG, and you can see the choroidal vessels really well. Once you get into a later ICG, like this next one I'm going to show you, the one on the right is an ICG, the one on the left is a fluorescein. You can see this little window defect close to the nerve. I'll try to point. Let's see if I can point. Here we go. You can see choroidal vessels, past it, right there. And it's because the choriocapillaris is also killed off in that area. So the RPE is done, and that's why you get a window defect on the fluorescein on the left, but then you're also seeing the choroidal vessels through that. And then this is a patient with polypoidal choroidal vasculopathy. Again, that's I didn't have to use an arrowhead. And then this is her OCT. She had subretinal fluid, and I'm showing you those choroidal vessels that you can see on OCT because I love OCT. And here's a patient with MUDES. Get all these hypoautofluorescent spots. I'm going to highlight a few of these. If you see an ICG, you should think of just a few disease processes. This is the most that you should think of. You could think of this as AMD, they're not going to show you on a test, but PCV, CSR are the two most important. I would say MUDES is the next most important. If you know those 4 will make it 4, choroidal hemangioma, you could basically narrow down what the A, B, C, and D to those 4 things. Now, if they have all 4 of those things on the answer, then you're screwed. But if they've only got one of them, you probably got it right. So MUDES, PCV, CSR, half these have the word choroid in their name. Serpiginous is another one, but that probably wouldn't be tested. And then the choroidal hemangioma. All right, so if they give you an ICG, look for choroid somewhere in the answers. All right, let's talk about EOGs really quick. All you need to know about EOG is that if they're showing you an abnormal one, they're talking about Best disease. If you remember that, you probably got it. what we're looking at is a standing potential. There's a difference in the electrical signal between the top of the RPE and the bottom because of the zonulae occludentes that have this impermeable membrane, or it's doesn't allow passive diffusion of any kind of thing. And so what you're looking at is you have the lights off first, and then you have the lights on, and you have them look right and left, and you measure that standing potential by having them look right and left because you have electrodes on the skin of the medial and lateral canthus. When you measure that difference, when they're moving right and left, when they're in the dark, it's a little bit lower. When you have bright light hitting the eyes, you get a difference in that whatever that gradient that's causing that gradient. Nobody knows what it is, and that causes the difference, the standing potential, to be greater. Then you divide the high point of the light peak to the dark trough. If it should be 1.85 or greater, that's the Arden ratio. If it's less than that, it's abnormal. If it's less than 1.3, it's severely abnormal. That's like in the range of Best disease. Again, there's a lot of things that cause the ERG to be abnormal and the EOG. Best is one of the few ones we talk about has a normal ERG because it's just the center that's involved, so we think, and an abnormal EOG. Okay, I already said all that stuff. Okay, here's our last example, and I think this kind of brings it all together. I would love to call on somebody, but it doesn't. We'll just kind of proceed. This is a patient of mine, not presented at grand rounds. Some of you might know him. Progressive hemerolopia. Does anybody have a quick 2-word definition of hemerolopia? Day blindness, right. So high contrast scenarios. So twilight and dawn, dusk and dawn, when the light's very horizontal, they are just incapacitated. Any of you guys ever go eat at that Greek place across the street, Mina and Demi's? Really good Greek food, but it is super dark in there. But they always have their windows wide open. They don't have any curtains, so it's always bright light. So if you sit on one side facing out, you can get a sense of what hemerolopia is like because you're trying to talk to somebody who's in a silhouette, and you're like, I feel like I have a cone dystrophy here, And then you sit on the other side, you're like, oh, this is great. It's like driving home, and all the sun's kind of behind you and everybody else's eyes. I feel like I've got cone dystrophy when I go to that place, but I love the food and I keep on going back. I just try to get to my seat first because everybody's always racing to get back to the window. So he's got decreased vision, hemerolopia. He's having a hard time taking tests, especially on computers. He's taking much longer. He's getting bagger. He's not even getting close to the end. This is what kind of image is this? Is this a red-free, infrared, fluorescein angiogram, OCT? What? Autofluorescence, right? Good. So dark in the center, dead RPE, a little bit of a ring, a little bit of hyper autofluorescence or hyper AF. So maybe some sick RPE around that, right? Here's his color. He's fixating okay, maybe. I mean, somebody can actually make you fixate poorly just by moving that little rod around. Here's his OCT. Look, we've lost his ellipsoid zone, his interdigitation zone. All that stuff's gone in the center. He's got RPE atrophy inferred by his hyperreflective choroid. We didn't talk about that too much. It just kind of corroborates what we've already seen. So what do, I send him for ERG and genetics with the diagnosis of cone dystrophy. Send him for his ERG. We've got a rod response, maximum response. Does that look normal or abnormal? The rod response definitely looks normal. Again, we expected that to be normal. The maximum combined response, the B wave doesn't go up super high, but he fell within normal on his amplitudes. His implicit time is a little delayed. We didn't talk about that too much. We're going to say, but normal. So we want to look at his cones, right? Well, the cone response looks okay. 30 hertz flicker. He's responding. I can't tell you looking at his amplitudes if that's normal, but I could tell you because I looked at all the numbers and he didn't highlight any red. That's what Dr. Harrison does. He highlights them red if they're abnormal. It's the good stuff. Normal. Okay, so is it still a cone dystrophy? Probably not. His cones are responding. Cone dystrophy affects all the cones. And again, you've got the highest concentration, 140,000 per millimeter squared. I don't know why I remember that. You guys probably don't remember that, but I just gave a lecture. 140,000 per millimeter squared in the center. That's 745. But 90% are outside of the fovea. I think they're outside of the macula even. His multifocal ERG, little squiggles in the center, are smaller little mountains and valleys in the outer portion. So his multifocal is abnormal, right? And so finally, before they cut me off, I got his genetics back. He has 2 mutations in his ABCA4 and 1 in his GUCA1A. Well, all those can cause cone dystrophy. GUCA1A is cone dystrophy specific. But the ABCA and the ABCA4 can cause cone dystrophy. It's been associated with AMD, probably not, but Stargardt's, right? So based on all of that stuff, I have to say, well, he's got Stargardt's. He came in with hemerolopia, but I guess you can get that with Stargardt's. He didn't really have flex, and actually, I haven't gotten his Fluorescein yet. And last time I saw him, I said we need to get a Fluorescein. I didn't even think about Stargardt's early on because it's just what he was saying. I didn't see any flex, blah blah blah. But he's got Stargardt's. So that's the story on that. ERG is very helpful. The ERG really sealed the deal because if I got his genetics back, I still would have said this fits with cone dystrophy. So his ERG helped me make the diagnosis. This is a picture I took with, what's that? Exactly. And I took about 5 pictures and then averaged them all together. But I took, the HDR. So anyway, thank you guys. I'll try to get the OCT image just emailed out to somebody and they can send it out down the chain. And I'll try to put most of these up on my website at some point. Thank you very much.
So